Good evening and welcome to the next installment of UOA On Demand. My name is Dr. Patrick Buckley and I'm joined by my partners here, Dr. Charlie Gatt and Dr. KG Swan. We're here to talk about ACL repair and kind of the cutting edge and the treatment of what we're going to be doing for athletes who have this type of a problem. We're going to talk about really what it is, who's indicated for it, go through our experience of treating these athletes with this kind of newer and emerging technique. And I'm sure this is something that we can all talk about for about 4 or 5 hours. So we're going to try to limit it to about 30 minutes here. But KG, Charlie, great to see you guys.
Thanks, Pat. Good to be here.
Pat. So I think we maybe first start by going through a little bit of the history of ACL reconstruction. And Charlie, I thought maybe you might be able to talk a little bit about how this has evolved over time from open techniques to arthroscopic techniques. And now we're talking about repair.
I mean, a long time ago, way back in like the 1980s, before ACL reconstruction was even a procedure that many people did, open repair of the ACL was performed for relatively high-level athletes. And the surgery was done through open surgery and stitches were placed into the torn ACL. It was actually still, the technique is similar to what we're doing today, where it may have been tied over a bone, but sometimes it was sewed together. But patients were put in a cast after surgery and oftentimes kept in the cast for 6 weeks with their knee bent a little bit. And that led to a lot of knee stiffness and muscle atrophy. And bottom line is the patients really didn't do very well. It was an operation that made the knee very stiff and didn't really have a high success rate and had a high failure rate. Fortunately, we got away from that, went to ACL reconstruction, which has really done very well for the last 30 years. And we got a lot of patients back to playing sports, but there's been a renewed interest in ACL repair because now with arthroscopic techniques that are available, we can do the repair without opening up the knee, so there's much less trauma to the knee. We know with some of our newer devices, we don't have to immobilize the knee because we can start early motion without damaging the repair. And this has made it a viable alternative for patients in the year 2023.
Yeah, and so I think it'd probably be good for our audience to talk a little bit about what the differences are between an ACL reconstruction and an ACL repair. So Dr. Swan, can you maybe kind of talk about how you frame that for patients when they come in to you with an ACL tear and you start going through the options of treating that?
I do, yeah. So for many years now, most of my career, if someone has an ACL injury and they're deemed to be an operative candidate, and what I mean by that is not everyone who tears their ACL must have ACL surgery. Some people do okay without surgery. And that's part of perhaps our discussion later on in terms of who gets a reconstruction, who needs a repair, who needs non-operative treatment. But for most of my career, people who came into the office and were deemed candidates for ACL surgery because they tore their ACL, they would get an ACL reconstruction, meaning we have to put a new ligament into the knee, new tissue into the knee to make a new ligament because the one that was injured or torn was not going to heal. We've learned that over the years that the environment within the knee is not conducive to ligaments healing very well compared to ligaments more on the outside of the knee, which may heal better, not in a little bit different environment. So we reconstruct the ACL, meaning we take tissue and put it inside the knee. We use screws or buttons or other fixation devices to fixate this new tissue, typically from elsewhere in the patient's body, but sometimes from a cadaver graft. And then we can reconstruct the knee ligament, the ACL ligament, and get them moving early on. That's an ACL reconstruction. Some patients have said over the years, oh yeah, Dr. So-and-so did my ACL repair. What they probably actually meant was it was an ACL reconstruction if it was done in the 90s or 2000s up until now. But nowadays, we actually are kind of coming back to the pendulum swung back, and ACL repair is a better option once again. And that means that we're maintaining the tissue that's there. The ligament that was torn may be of such a quality that we actually can keep it and repair it back to where it tore off of and perhaps enhance it and allow your own tissue to make a new ligament rather than taking it from elsewhere in your body.
I love it. I think I'd sign up for surgery right now. So as
Very
we
good.
all know, I think there's a number of success stories, but there's potential drawbacks from ACL reconstruction, and I think that's probably the foundation that led to the idea of repairing your ACL versus taking a graft from somewhere else. So, Charlie, maybe talk about what your experience is with patients who maybe struggle a little bit after an ACL, and what the benefits of a repair may be versus a reconstruction.
Well, actually, one of the most painful parts of the operation is actually the graft harvest. We have multiple choices in how to reconstruct an ACL. We can use a portion of your patella tendon, the big tendon that goes from your kneecap to your shin bone. We can use 2 of your hamstring tendons. We can use a portion of your quadriceps tendon or your thigh muscle. And just the process of taking that portion of the tendon out of the knee to implant into the knee is a source of pain. So that's one of the reasons that may result in patients being, a little nervous about moving their knee, and that can lead to stiffness. You can result in some scar tissue around the site of the harvest, which also can lead to stiffness. So these are probably one of our most common troubles after ACL surgery is knee stiffness. If you don't get it back early after surgery, sometimes it can be a little hard to get back, and even there are some times when we have to go in after surgery and remove some scar tissue to get all the motion back. So these are some of the troubles that we see with ACL reconstruction surgery that we might be able to avoid with an ACL repair, because now there is no graft harvest. We just, again, go into the knee arthroscopically through small holes, and we're able to sew it back without the trauma of taking the graft.
So I thought now would be a good time to introduce the idea of ACL repair and the Bear implant, which is something we're going to transition and talk about. So we can dive into this more, but this was kind of one of the landmark studies and really the culmination of probably around 20 years of research from Dr. Martha Murray up in Boston Children's Hospital that looks at really, is there a way to repair your own tissue? And the Bear technique or the Bear implant is really the fruit of all of that work, the whole lab and team that she kind of leads up there. And I would say that, at least personally, this is probably one of the most exciting things within the field of sports medicine that I think we've had come around in the past, probably few years. And the basic idea here is that you take a torn ACL, which is kind of pictured on the left. And I would say that ideally you're trying to have a torn ACL that is off the femur with a stump of ACL left onto the tibia. You're suturing that, and then you're kind of bringing that back to the femur or repairing it back to the femur. And then in between that repaired tissue and the femoral bone, you're going to place the Bear implant, which is kind of pictured here in spot C, allowing those fibers of the ACL to heal back to the femur, and then rehabbing it appropriately afterwards. This is kind of a video I think that all of us would agree is probably an ideal candidate. And this is really the person, at least personally, that I'm indicating right now. So you're looking at an arthroscopic video. This instrument is called a probe. And this is what an ACL looks like at the time of surgery. The ACL runs from the lateral condyle, which is on the left. That's the part of the end of the femur, and runs to the tibia. And this frankly looks like a really good ACL. It's attached nicely to the tibia, but you can see that with the probe that it's not attached to the femur. And so this is one that in my mind, in many years, you would in the past go in to take out and sometimes wonder, could this heal? And I think now the data is saying that that certainly is a possibility, and that's something that we've started doing, and the results are quite promising. So these are arthroscopic pictures that look at the ACL repair, and there's a tunnel here into the femur, which is what you would pull your sutures up that you've placed in your ACL and kind of tie them over a button on the outside of the femur. These purple sutures are a absorbable suture that's passed with this device, which allows you to pass and suture arthroscopically through the actual ACL stump. and that is pulled up through the tunnel on the tibia, and in between the bone and the actual ACL stump is where the bare implant is placed. And so I think that's kind of an important bit of background that I wanted to bring up for our audience and show them what the process of surgery is. But I'll do that and open it up to you both and say, who are you indicating this on, and kind of who's the right person for you in 2023 to say this might be the right surgery versus an ACL reconstruction. So Charlie, do you want to take that?
Sure. Yeah, I think, well, first of all, I do like to look at the MRI, and Dr. Buckley showed a beautiful picture of an ACL that had kind of pulled away from the femur or the thigh bone. And so you can pretty much tell that on an MRI if that's the type of tear. So, and again, as he pointed out, when we looked inside the knee prior to this bare ACL repair, we would look at that ACL and say, felt a little guilty taking the whole thing out and reconstructing it with another part of your body. Now, with the MRI, you say, oh, well, this is a perfect candidate for a repair, because I know I can put good stitches in that and sew it back together. And I think, so that's probably number one on my list. And the number two is, somebody who wants to lead an active lifestyle, and instability of their knee would, stop them from doing some of the recreational sports they enjoy. So anyone who's participating in cutting and pivoting sports, would be a candidate for the repair.
And KG, what about you? And maybe who would you kind of steer away from this, or who would you hesitate a little bit on indicating a bare surgery today?
Right. So who not to put this in? There are some contraindications, which might include those that are chronic. So I think we've learned from the guidelines that you want to do a bare reconstruction on a relatively new ACL, somewhere within the first 2 months, we think, of that injury, rather than one that's been torn for many years. Someone who has multiple ligaments injured, for like a knee dislocation, and many other ligaments that need to be reconstructed. I don't think I'd be doing it on that, in part because other injuries that may require a different rehab protocol afterwards, other injuries around the knee, could complicate how you're going to rehab the bare reconstruction. And then I guess the big question is the age of the patient. Can the bare reconstruction withstand the forces that a teenage high school or college ball player or professional athlete will experience? And I don't know if we have all that data yet. Right now, it seems like perhaps my best candidate would be a recreational athlete in their mid to late 20s or 30s who has an ACL that's pulled off the femur recently, and wants to maintain that active, healthy lifestyle.
Sure, and I would agree with that. I think that one of the things that might be interesting for the audience is to kind of understand what we still don't know about, ACL repair, and to realize that this, our field and this problem, although ACL injury and surgery has been around for, probably 4 or 5 decades, this is still evolving, and we're still learning about this. And I think that all of us have a conversation with, our patients to try to go through this with them and say, look, here are the pros and cons. And this is what we do every day. We talk about what are the options, what are your goals, what's your individual characteristics that we need to weigh here. And then we make the best decision together for that patient, versus saying this is an easy, everyone gets the same thing type approach, because I don't think that's the reality in this situation. So
yeah, agreed.
I think Dr. Swan brought up a really good point about, what the patients are going to go, like the younger patients, to go back to, high demand sports. And even though the original work on bare was done in younger patients because it was done through Boston Children's Hospital, when a patient has to have an ACL reconstruction surgery or ACL surgery, they're not going to return to sports at the earliest, for about 9 months. And so that's giving up an entire season of sports. And so we have, 30 years of experience with ACL reconstruction, and we know what the risk of re-tear is for the most part. But with the bare ACL repair, the data, we have 2-year data. We're waiting for 6-year data to come out. So we're still, we can't have the same confidence that we have with ACL reconstruction. I think we have to be honest with the patients that, we think this will hold up as well as an ACL reconstruction. And so far, that's what the data tells us, but we're not 100% sure. So if the next season's very, very important, they have to make that decision. Do they want to go with this newer technology or go with what's been tried and true for about 30 years now?
So I'll tell you what I hear in the office, and I'll say to you, Charlie, but I have a lot of patients who come in and say, well, this is a faster rehab and this will get me back to the field quicker or sooner. So how would you answer that?
So I hear the same thing, and that's I think that's something that needs to be clarified to the patients. It's important because with ACL reconstruction, we're putting in a graft that's strong and it's fixed strong, and the early rehab is actually rather aggressive in terms of getting motion back. People can put weight on their leg almost right away. With ACL repair, we're waiting for the ligament to heal, and healing takes time. And so the early part of rehab is actually slower and more protected than ACL reconstruction surgery. So it's not faster for sure. It may even be a little bit longer, but there's advantages to the repair that ACL reconstruction doesn't have to offer. So I think that's very important that patients understand that.
Yeah. KG, can you outline kind of your protocol after surgery when you do a ACL repair?
So repair, as Charlie mentioned, is going to be slower and a little different than an ACL reconstruction. ACL reconstruction, we get you in therapy right away, and we get the knee moving right away, typically with limited, if any, restrictions on how far you can bend and extend the knee. And we get you walking most of the time after an ACL reconstruction within about a week. That'd be probably somewhat typical. For the bear procedure, we protect your weight bearing for longer. For the first 4 weeks, you are using crutches, and we limit your range of motion early on. For the first week or so, we're not doing much range of motion at all, only going from about 0 to 30 degrees. And we gradually increase that, but your range of motion is not progressing as quickly as it does with the typical, more classic ACL reconstruction.
Yeah, and I think for a lot of people, like in an office setting, like that matters, because for an ACL reconstruction, you can probably get to 90 degrees quicker and sit in a chair and work, a lot faster than you can with a bear, where you're potentially staying straighter longer, and you kind of have to factor that into the early part of the reconstruction. Excuse me, of the repair. Most people after a bear surgery would be on crutches for about 4 weeks. They're in a brace, and that brace is really going to be locked straight, especially for the first 24 hours, and then progressing for the first 2 weeks to around 30 to 45 degrees. And then after 2 weeks, you're progressing to 90, and then building your full motion after that. The timeline at the end of this is really the same for me. This is 9 months back to a return to sport. This is not a quicker timeline. And I think that's an important thing to highlight. So I wanted to show that, for both of us. And I think this is where, to me, this is very exciting. And I think this is a very emerging part of the field that for the right person who is interested and kind of does their homework and understands the pros and cons, I think this is very exciting and is a really great option. But this is a frankly longer discussion that, you have than before this was an option, because we didn't have this, and it was mostly you're talking which grafts are you doing and the pros and cons of that. So, I'll open that up to you both as far as how you're using this and maybe how you see this evolving in your practice over the next couple of years.
Well, I'm curious if I think we all agree that the proximal tears, the ones that pull off the femur, are very much amenable to this, sort of like the one Dr. Buckley showed there in the video. But what about mid-substance? I know there is some indication to that, and I'm curious of both your thoughts on that, or when will it turn to us doing that more frequently?
Go ahead, Charlie.
Well, I think, again, it's one of these cases where you have to arthroscopically look inside the knee and decide, can I put in good stitches that will bring the tissue relatively close together? And I think even if it's a mid-substance rupture, as long as I feel like I have tissue that I can grab and bring next to the other piece, it might be something we try going forward. But right now, it's like everything that's new, once you get comfortable with the straightforward case, you start to expand the indications and then try it on maybe something that's a little bit more challenging, and we'll see the success of that. And if it pans out, then we'll even do those cases as well. So it's going to take a little bit of time.
So for me, I would agree that the mid-substance ruptures are kind of a yellow zone right now, or a yellow light and a caution light. For someone who might be very interested and understands kind of the pro cons, I think it's reasonable because there is some data to support it within the bare literature. But I would say for the most part, and everyone that I've done so far has been a femoral sided tear that I really know that I can get good sutures into that tibial stump of the ACL and bring it up to the femur. So this is where this will evolve with time. And I think this is where, for us here at UOA, where we kind of keep abreast of the literature. I wouldn't say that we, are ones that bring every brand new object to our patients, but when there's good data and good science to support it, and we think it can help them with their outcome, these are options that we're going to talk to them about and go through in the office. And I think that's where this is going to continue to evolve for me.
Yeah, I think a good question, that patients have asked me is, well, like, why do a bare rather than an ACL reconstruction if it's worked, if that works so well? And, if you think about it, patients that have ACL reconstructive surgery generally do very well, but they'll oftentimes tell you their knee doesn't feel normal, not 100% normal. Why doesn't it feel normal? Well, the graft initially, when we put it into the knee, isn't even living tissue. And there's a question of whether it, if any nerve fibers grow back into it. So there's a concept called proprioception, which is a fancy word that means, does your brain know the position of your joint in space? Like, is my knee bent? Is my knee straight? Is it twisted in or twisted out? And you don't really regain all of that proprioception when you have an ACL reconstruction surgery. But theoretically, with ACL repair, you do maintain those nerve fibers, and we may find that patients have better proprioception. In other words, their brain knows the position of their joint in space better, and their knee may feel more normal. So again, we have something that works very well, but we can make it better. I think that's the exciting part about this in terms of, like, why would you want to do this going forward? Because it takes that next step to getting us back to a normal knee, right? So rather than using tissue from another part of the body, we're getting the native tissue in its normal position to heal back to normal. And that's the exciting part of it for me.
I agree, Charlie. I'd agree 100%. I think you're spot on with the proprioception concept. And the reality is that the ACL reconstruction is something we do, and we all three of us here, I believe we do it well, and we love seeing our patients back on the field. But some of the data that's out there, certainly at like the NFL level, I think we know there are some athletes who never get back to the same level for whatever reason. Maybe their rehab didn't go that well. Maybe it was the end of their career, or maybe they just don't have that proprioception that really helps them get back to exactly who they were. And if we can make it better, then this is exciting.
So I think this goes without saying, but if you're in the audience and you have an ACL tear, I think there's a lot of, I'd encourage you to get an evaluation with a specialist. And certainly I think the sports medicine specialist here at UOA can give you your options and talk you through all of these different nuances and facets that we understand and we live every day, and can try to fit the right treatment to you and what your goals are. And so looking and seeking out really leaders in the field that keep up with not only science, but also keep that grounded in kind of what their experience is and what your goals are, I think has a lot of value. And that's what we can offer you here at UOA. So I encourage you to research this. I encourage you to look us up on the internet, and to certainly call our office with any questions and make an appointment to talk about this in person. Because as we alluded to, this is a decision that you have to kind of understand all the parts of, and we can help you do that. So with that being said, I want to thank Dr. Swan and Dr. Gatt for being here tonight. And we look forward to potentially seeing you in the office. And certainly we'll talk more about ACL surgery and other topics like this in the future.
Thanks, Pat.
Thank you, Pat.